Hi, welcome everyone. Thanks for joining us for Advanced Echo Teaching the Critically Ill. It's nice to be back. Obviously a bit of a hiatus with COVID, and we're back, which is great. And hopefully we're getting back to normal soon. We're going to obviously got the DDU exam is coming up. That's the Advanced Echo exam in Australia. It's coming up soon in a couple of months or a month. So we're just focusing on Viva practice at the moment. So these are just cases that we're just going to go through. Got a couple of people online, so we'll just go through things as we go. Vishal, I might start with you if that's okay. Okay, so we've got a 41-year-old, and sorry, just for the exam outline, as I'm sure you both know, it starts off with a stem, something that looks like this. I've tried to put it as much like the exam as possible, and normally have a stem followed by about 4 or 5 slides, and we'll ask questions as we go. Okay, so 41-year-old female. She's 29 weeks pregnant. She's unvaccinated and COVID positive. Background history of asthma. She's got increasing oxygen requirements and she's sent to ICU for non-invasive ventilation. She's got a COVID pneumonitis and she's got a left lower zone opacification. This was her echo when she came in. Vishal, do you just want to tell me what you're thinking about these 4 images, and particularly the bottom left?
So do I have the number, in terms of what's the pulmonary acceleration time?
I can tell you what that is. The pulmonary acceleration time, let's say it is 80.
Sure. So I think, there are 2-3 things I was thinking, based on the stem and based on these pictures. So first thing, I would be worried about that how much PEEP or we are ventilating. And sometimes
non-invasive ventilation, remember.
Okay, so sorry, I missed that. It was non-invasive. So still, it's the PEEP is there. So I will be thinking about RV, dysfunction, pulmonary vascular resistance, and also depending whether the patient is shocked or not, septic cardiomyopathy as well. In terms of I'm not sure what day of COVID it is, but if it's getting infected. So I'll be thinking those things. And in the left bottom picture, so there's a flying W sign, so which is suggestive of increasing vascular resistance. And on the other pictures, the RV is mildly dilated. Difficult to comment on the function, but longitudinal function looks okay based on these pictures. And there's significant V lines on the first upper left corner pictures, which is.
I might just blow that one up actually. Just hang on a second, because I think it's a really important slide to show. Let me just loop that, because maybe we'll just ask you to, sorry, click on that just works like that. Yeah, just tell me about that image in particular.
So parasternal long axis and with increasing depth looking at the on the lung, and based on the like looking at the heart, so the LV function looks okay. The mitral valve opening is normal with aortic valve opening normally, and RV right ventricle size and function looks normal on this particular view. And looking at the lung, there's a bronchogram, or there's echogenic structure at the middle of the screen, which is suggestive of some collapse consolidation, because I'm not seeing it's a static or dynamic based on this particular view. And also there's some significant V lines going down the screen. So there's an interstitial pattern with the collapse consolidation in the left lung in this one.
Very nice, and that's obviously consistent with the COVID pneumonitis, with some form of either basal atelectasis or whether we've got some superbacterial infection on top of that as well.
Yeah.
Very nice. What walls are we looking at on the parasternal lung axis, please?
So anteroseptal and inferiolateral.
Okay. All right, take me through these pictures. So these are sort of more formal lung ultrasound images of her on that day that she came in.
So starting on the left upper corner, so there's this good sliding sign present with significant interstitial pattern, again, which is in favor of COVID pneumonitis. But then going on the left lower zone, which is getting more and more, the B lines pattern is getting more and more prominent. And also the same in the right upper zone, so there's significant interstitial pattern. Whereas in the right lower zone, there's at least mild to moderate pleural effusion with some collapse of the lung. And it's a plankton sign we can see on this one. And yeah, I think that's pretty much it. So
yeah, can you tell me about the left lower zone? What do we think there? Because that's different from the rest, right?
So there's an interstitial pattern, and also I think there's a bronchogram as well. So,
yeah, nice. And here we got the diaphragm. I don't know how well it comes out, but there's the diaphragm there with the spleen underneath it, and then this is the consolidation that we saw in that left lower zone compared to the others. So sonographic hepatization would be the word that I'd be after there.
Okay.
So,
sorry, the diaphragm, I thought that was the tip of the lung collapse.
That's it's fine. I mean, it's more the process. It's okay just to miss it now. But the I guess it's recognizing all those B lines. There's sliding sign there. The plankton sign, or we've got some form of maybe superficial infection. There's just in there. Can you see that there's maybe some little C line or something in there a little bit, or some subpleural thickening that's coming in?
Yeah.
Yeah, just in there. Yeah. I think that might be an indication of peripheral atelectasis or infection potentially that's in there. Beautiful. We'll come back to maybe the first bit. Just as an aside, and forgive me, Lewis, I know you've seen these images before, but she was pregnant. I think I tried to use this to have a look at her heart rate. If you're going to do this, to have a look at the fetal heart rate. So I'm not a sonographer for babies, but it is a nice and easy way. I can find the heart. I can find a baby's head as long as it's sort of older than about 12 weeks. You can find its heart, and then you just could put pulse wave Doppler over it for a brief period of time. You don't want to leave it there for like a second and cook the fetus. That's bad. But from there, you can start figuring out what the heart rate might be from figuring out. So, it's approximately about 130 beats a minute, maybe a little bit slow for a fetus. It's the kind of thing that, I did that, and it's the kind of thing to maybe call up the obs and gynae guys and say, maybe the fetal rate's a little slow. Do you want to have a look? They came and had a look, and it was actually fine. So it's probably just my dodgy measurement, to be fair. Okay, so she deteriorated. She got intubated. And she rapidly went on to maximal support. I think this was about the time, it was exactly just about an hour before this, I phoned you, Vishal, saying, I'm doing X, Y, and Z, what do we think? And absolutely we agreed that she needed to have an urgent delivery, and that's what we went ahead and did. This is what I want to show you though. So this is the echo the next day.
Oh, no, it's all right.
Every single.
When she starts to move into increasing hemodynamic instability. So when the baby first came out, there was an improvement in her cardiorespiratory status, but then the next day, again, a deterioration. So this is compared to that first one. What, if you can remember the first one, What do you think's changed?
So there are two important findings, as compared to the first one. The first, let's talk about the left ventricle. So the left ventricle is hyperdynamic and small ventricle size, and I'm concerned about mid-ventricle obstruction because looks very empty, and I need to have a look on the gradient in the apical flow chamber. But on the parasternal long axis and short axis, I'm concerned, it's very, very hyperdynamic and small ventricle, empty ventricle. Whereas the right ventricle is significantly dilated, and there's a D-shaped, septum, which is, probably, I think it's, I need to slow it down, but at the moment it looks like it's only in the diastole. So maybe it's volume overload pattern, but it could be volume and pressure overload pattern. I need to slow it down. So significant dilation of the right ventricle and the hyperdynamic left ventricle, which looks empty.
So we had pictures on that first one with that decreased pulmonary acceleration time and the flying W sign, and you called it mild RV dilation.
Yeah.
What has happened? What do you think? Take me to that next bit. You've described the images very well, but what's the clinical relevance of this?
So there are possible two clinical relevance. So first thing, now patient is intubated, and so what PEEP patient has been set, if we have cramped up very high PEEP, then the right ventricle can fail, and maybe the PEEP needs to be optimized. And the second bit is that you would be thinking what could be the causes of high vesicle resistance and acute deterioration in the right ventricle size and function. So I'll be thinking in terms of obstruction, in terms of the pulmonary embolism. I need to rule out because patient deteriorated very quickly. And but having said that, I know a little bit history about the patient, so
Interesting, pneumothorax. Sorry, again, did you hear that? Ben was suggesting could it be pneumothorax? So, I mean, I think if it's a pneumothorax, you're not going to get the RV being dilated, are you?
Yeah.
Because
that would be the confound. The RV dilation is increased over the window, right?
And that's what the main clinical thing is, and that's what the candidate would obviously have to be able to pick it up, and probably be a little bit better images. We'd probably have comparisons for you, and probably not 4 images in there. It'd probably just be one image in the actual exam. But the main factor that I think needs to be picked up is in those first images with that reduced pulmonary acceleration time and the flying W sign and a mildly dilated RV that's working okay. You might say that that's an RV at risk.
Yeah.
Mm-hmm.
This is not an RV at risk. This is an RV that is failing because we've got clinical signs of deteriorating hemodynamics, and we've got, I think this is a D-shaped septum throughout the cardiac cycle. And you can see that particularly, I think, in the subcostal one. That RV is twice the size of that LV, and I think you can see it up here. But I don't think that would be a major sticking point, saying if that was diastole or systole, to be honest. But you picked up the big things. The RV is huge and it's not working well, and we've gone from being an RV at risk to a failing RV. I don't think pneumothorax gives you that. I think pneumothorax just stops blood going into the heart, right? It's just an obstruction from the heart being squished.
Yeah, you can have an empty right heart rather than an overly full right heart. But,
So I think the diagnosis you gave, Vishal, where it could be the mechanical ventilation, and it could be PE, which I think is pretty solid. The other ones I thought that we could add into that was it could just be worsening infection, particularly bacterial superinfection, because the respiratory requirements are going down as well. And so it could just be a worsening clinical respiratory state.
But even that can cause an acute RV failure?
Absolutely. When you say acute RV failure, do you mean ischemia?
No, in terms of saying infection, worsening infection, but would that cause acute RV failure?
I mean, I think if you've got someone, if she's got a pneumonia on the left side, if that pneumonia was getting worse and moving into a ARDS pattern, so you've got terrible oxygenation, terrible hypercarbia, worsening pH.
Sure. Yeah.
I think that could, it's basically anything that can increase up your RV afterload in isolation.
Yeah.
Nice. So I guess the learning thing there is just keep your answer broad when you're in the exam. Just don't hem yourself in, I think.
Yeah.
Okay, what about this, the last bit?
So there's horrendous, tricuspid regurgitation. So, both, so in the continuous wave, through the tricuspid valve. So both the profile and the density of the TR wave is suggestive of, severe tricuspid regurgitation. And also the color Doppler is also suggestive of, which is, sometimes overestimate, but I think the continuous wave is the key where, both the profile and density showing severe tricuspid regurg.
Take me through the profile. What do you mean? How do you know it's severe based on the profile?
Because antigrade and the opposite, the density is almost the same.
Yeah, nice. The other thing is the shape of the profile. What do you
so that's a profile. Yeah, so it's cutoff sign. Cutoff.
Good job. Cheeky, you get that?
Yeah.
All right. Yeah, she did have PEs. We thrombolized her, and things started to get better. Okay. Last question. Maybe we'll ask Lewis. Can I ask you this question? Hi, by the way. Sorry, I muted you. I'll unmute you. Sorry, I then muted you again, Lewis. I do apologize. We were both trying to do it at the same time. You okay to unmute yourself, buddy? Thanks. Sorry. Lewis, hi, good afternoon. Can you tell me the echo features of pulmonary embolism?
Echo features of pulmonary embolism. Yep, sure. They're characteristic of an acute increase in RV afterload. So there's a bunch of validated features, but generally you'd look for features of a volume overloaded RV, so RV dilatation, increased RV-LV ratio. You would look for TR and look to try and measure a pulmonary pressure. Elevated pulmonary pressures in the realms above sort of 60 millimeters of mercury are rare in PE. So you'd be looking for sort of 45 to 50 plus the CVP.
Yep.
There's a couple of other well-characterized features such as the 60-60 sign, which incorporate the pulmonary pressure, but also look at the pulmonary acceleration time as well. And as you said, the flying W sign, the mid-systolic notching, has been characterized in
So you
PE as well.
So the 60-60 sign, so that what was that? So 60 is the pulmonary pressure less than 60. What's the other 60?
Pulmonary acceleration time.
And is that greater or less than 60?
Less than 60. So
Yeah,
short pulmonary, yeah. And then there's obviously the most sensitive and specific feature, which is a clot in transit, if you can spot it.
Any other 2D features? What about RV function?
Yeah, so sorry, I didn't do that. So reduced TAPSE, reduced fractional area change, all those things will be seen and consistent with acute PE.
Well, give me the last one, the last little piece of the puzzle, the regional wall stuff.
Oh, McConnell's. Yeah, thanks.
Cool.
And and one obvious, clots in the pulmonary artery.
Yeah. I think you said that. Thrombus in transit, which has the best sensitivity and specificity of them all. Yeah, sure. Lewis, do you want to have a crack at this one?
Yep.
Okay, so discuss the following Doppler traces. And I love these questions. So tell me what they are. This is all you're going to get. You've got to tell me everything about it.
Okay, so continuous wave through the mitral valve shows a so it looks like a mitral valve trace. It looks like it's consistent with, probably a moderate MR when you look at the density, mild to moderate MR when you look at the density. It varies in terms of velocity.
Why is that?
Which it might be because of rotational translation of the heart and sort of varying angles of intonation through the valve, or it may be because of varying pulse pressures that occur across the mitral valve. And so you'd look at the LV function and you'd see whether there's a cardiomyopathy there that might be resulting in a low stroke volume, varying stroke volume. What else is there? So in terms of the overall velocity, it's relatively low for a MR, and I'd want to know what systolic blood pressure was, but I'd be thinking that this represented an ailing ventricle as well. It wasn't able to generate a high pressure.
Very nice. What do you think about the rhythm?
For full marks. So it's a wide QRS.
Yeah.
It's a wide QRS. Can't see any. I can see an. Yeah, look, I can't clearly see a sort of EA profile in the. So it's probably slow AF with a wide QRS.
Fantastic, and that's why we've got probably variation between the stroke volume with each beat. Yeah, nice. And absolutely. So I guess the big features, you mentioned all of them. It's that dense parabolic profile of mitral regurg. We've got atrial fibrillation. We've got low velocities. They're less than 4, which suggests a low cardiac output state. And very sensibly, you're asking for the blood pressure. I think that's everything in there. That's good. Excellent. All right, have to go to the next one.
And sorry, Sam, that in the previous one, would you mention that it can be optimized a little bit better because
Yeah, nice. Yeah, in what way?
because like the velocity is up to less than 4, but the velocity scale is almost 5.5, so we can
Yeah, nice.
decrease the scale. And other thing is, in the 2D picture, I can't see the color Doppler, the jet, so I'm not sure whether the angle is correct or not.
Yeah, nice, very nice. Yeah, I think those would be definitely optimal marks. Beautiful. So, all right, keep going, Lewis. So this is an apical 4-chamber view with pulse wave Doppler.
Yeah, so it looks like it's probably distal to the left atrium, so it'll be pulmonary vein.
Beautiful.
So right up a pulmonary vein usually, and there is. Do you want me to talk about optimizing the picture?
Yeah, nice. Yeah, absolutely. You can bag on my picture.
So it's a.
I love it. I love feedback. It's great. I'm really good at it.
Dynamic feedback. Handle it well.
So it's difficult to interpret, and I'd want to understand the context of why the pulmonary veins are sort of being interrogated, just to
short breath.
Short breath, yeah. So looking for MR, looking for the diastolic features. The baseline is sort of not in the right place to clearly see features of MR. I'd want to see a little bit further below the baseline. The scale is probably relatively optimized, and you're limited by the amount of optimization you can do because of the Nyquist limit. And
Nice.
the background gain is a little high. That makes differentiating the waveforms hard.
What can you see though? Tell me what you can see.
Yeah, so what you can see is you can clearly see a well demonstrated, I guess, so it looks like a big S wave with, no, hang on, sorry. So it looks like a small S wave and a big D wave.
Nice.
With a, yeah, look, it's the D wave's got a very triangular appearance that is, yeah, I don't think I can interpret much more than that, other than to say that the SD ratios.
So yeah, you've got the S wave from beginning of QRS to the end of the T wave, that's systole, and we've got a small little nubbin of flow above the line coming towards the probe.
Yeah.
And then in diastole, from the end of the T wave to the beginning of the QRS, we've got a big D wave. So you've got a small S wave, massive D wave. What's this?
So that's the AR. So
nice. And that's pretty big and pretty dense, I think.
Yeah.
So agreed, it could all be optimized, but what you can still get some information from this. What is it?
Yeah, so it looks like a very abnormal SD ratio.
Yes.
With I will normally measure out the AR time.
Yeah.
And
you compare it to
so you compare that to the A duration.
Fantastic.
So the yeah, so the A to AR ratio as well. So it looks like it's probably elevated filling pressures.
Perfect. So raise left atrial pressure. So that would be, again with the marking grid. So the exam takes place in 2 different centres with different examiners. So we've written exam sheets so that we're all make sure we're marking exactly the same way, same as like college exams all over the shop, right? And so for this question, I'm sure that the tick is going to be, recognizing the S, the D, the AR, and then the big tick is a pass or fail is, do they say raise left atrial pressure? And left ventricular diastolic pressures is fine. But that would be where you've got to stay straight out of the gate, raise left atrial filling pressures. Yeah, nice.
All right.
Okay, what about this one?
Okay, so it's a once again the rhythm, no clear P waves. The duration of QR is quite prolonged. The E wave velocity is very high. So there's a couple of possible reasons for this. It could be severe mitral regurgitation. It could be severely elevated left ventricular filling pressures. The E decel time looks like it's fairly short,
Yeah,
which would be consistent with both of those.
Good job. All right, Ben.
Yo.
Have a go, Liz. Just discuss these measurements.
Okay. So I'm looking at a parasternal short axis of the aortic valve.
Yep.
And the measure in question is the measure of the aortic valve area.
Yep.
So my first issue with these measures is that the valve, the annulus of the valve, cuffs all be quite calcified, which can cause difficulty in getting accurate measures of the aortic valve area. So from that, I'd question the validity of this as a measure. Certainly, just on visual assessment of the B mode images, it does appear to be a small aortic valve area, so that can fit with the index value of less than 1. So on visual assessment, it does appear to have fixed aortic stenosis. The planimetry number fits with that, but I'd be skeptical of the true validity of it.
So other than the calcification, what else makes it tricky
to measure?
Yeah.
So I guess with respect to the still image that's there on the other screen,
or just the measurement in general.
So planimetry has pitfalls. You need to be completely in plane with the valve, so that's maximal opening area.
Yeah.
You need to make sure you've got it as most open.
Yeah, very good.
Just typically in the first phase of systole.
Yeah, nice.
So you need to check those things, which I can't do on it still. That's
really
good. And then there's the calcification. There's measurement error as well.
And I think you're also got to take it at the area. We're trying to estimate the orifice of aortic stenosis, right? And so we're suggesting that the orifice is exactly where we're in plane.
Yeah.
Nice. So the tips as well as exactly perpendicular. Yeah. What about that one?
So I'm looking at a parasternal long axis that's presumably zoomed over the aortic valve and LVT. I'd start by saying the measure that's up there at 2.7 centimeters seems large, although I don't know if that's the person, so we can index it. So with respect to this measure, the timing compared to the ECG, so it looks to be probably mid-systole. I'd like to probably touch it earlier, like in the first half of systole. This should be a inner edge to inner edge measure, and it should be approximately half a centimeter into the ventricular side of the aortic valve, so half a centimeter from there, which I can't pick from this still. I'm not sure where exactly the cusps are joining in.
Pretty good. Nice. Good. Okay, Vishal, it's the cracker.
Yeah.
Okay. How are you going to assess aortic stenosis in this patient? 70-year-old female, presents with a syncopal episode. She's got severe AS for investigation. She's not super easy to image, but tell me what you think about this Doppler trace before I show you some toe images.
Sure. So it's a continuous wave to the aortic valve, and the very faint aortic stenosis continuous wave trace, and which is suggestive of severe aortic stenosis based on that the maximum gradient is more than 4. But I need to see the mean gradient as well. But on this particular view, it's more than 4.
Cool. Okay, let's just take you straight to the. So the question is severe aortic stenosis. So we do some toe images.
Yep. So it's long axis view, and in this aortic valve, leaflet looks normal. There's no calcification, and it's opening normally. So based on these 2D images, it's not suggestive of any significant aortic stenosis.
Yeah. So where's the gradient coming from? I'll tell you what, how about I show you all four images and then we'll come back to it, all right?
Yeah. Yeah.
Awesome. Yeah, it's a fantastic study.
What do you think?
So I think looks like in the last one there's aortic membrane.
Nice.
So below the aortic valve leaflet, you can see there's echogenic structure both superior and inferior, and which is probably causing the obstruction. So it's not the it's aortic membrane basically causing the
Yeah, the subvalvular apparatus or the aortic.
subvalvular. Yeah, that was I was asking.
Very
Yeah.
nice. Now, the aortic valve looks absolutely fine, doesn't it? But let's imagine that the aortic valve doesn't look fine. And she's 70 years old, she's got a bit of calcification. And not unreasonably, the cardiologist who she's seeing wants to know the valve area of the aortic valve. How are you going to determine the valve area of the aortic valve with that subvalvular apparatus?
Because I think the valvular area would be normal because there's no.
Let's say that it's. I agree, it probably is normal in this age, but let's say that she does have some degree of aortic stenosis in there. My question to you is, how are we going to try and figure out what the gradient is through her aortic valve if there is a subaortic membrane?
I think then, I'm not 100% sure, but I would think that we may have to use the modified Bernoulli equation.
Brilliant. That's exactly what I'm getting at. And how would we do it? So talk me through what we do normally in the continuity equation, and then what's the modified continuity equation?
So normally the gradient which we measure is a 4v square, but if the gradient is more than 1, or the velocity is more than 1, then you use 4v1 square minus v2 square. So for example, LVOT normally velocity is less than 1, so that's why we don't count it, and we can ignore it. But if your velocity is more than 1, then you need to do v1 square minus v2 square.
Thank you very much. Very nice and done. Okay, case 5. Lewis, this one is definitely for you. I was hoping you were going to join us, and I wrote this question.
I wish you can ask me this one.
No, you're not allowed to ask. So, Lewis, my man, let's go through the valve scallops for each of these views. So these are all going to be normal views. But tell me what mitral valve scallops we're seeing.
Fantastic. A2P2. Harder.
You can pass me on whenever, Lewis.
No, whenever you want. No, Michelle. You're going to see why. Because in a minute, I'm going to show you the slides that you did for your talk.
I'm going to say A1, A2, P3.
Oh, yeah, pretty bloody good. I have a P2 in there. So A1, A2, P3. Yeah, nice.
Okay. And this is, so P1, A2, P3.
Man, fantastic. Would you have got this?
No, I know all of them.
Okay, so this is these are great. I love asking about Doppler in the exam, and I love asking about M mode, and I love asking about the mitral scallops, because I think if you can get those, you know echo, right? You can't look at an M mode picture of LVOT obstruction and that parasternal long axis and not know echo. It's just because you have to think in all those different dimensions. For the scallops, I think I've probably shown everyone in this. I don't use this one. I stole this off Twitter. I should probably have given credit to the person I stole it off. I'm sorry, I've forgotten. But I love this because I just remember that I sort of have my sort of 0 and then 60 as being a cross, and then 120. So I've always got my left hand as being the way I remember it. And so that means that for your apical 4-chamber view, you're not quite at 0, you're a little bit off that maybe, but yeah, you've got your P1, A2, A3. Did I say P3? I'm so sorry, I meant P1, excuse me. So A3, A2, P1. And then apical 2, you're through all of them for your P1, A2, P3. And then for your parasternal long, as you said, A1, A2, 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 P2, and that's beautifully done. And then this is from Vishal's lecture that he gave. That means when you're at 0, you've, it's like the apical 4, I guess, and you've got the A2, P2. On the apical 4, sometimes we're a little bit tilted round, and that's why you can have that A2, P3, A2, A3, and P1. Two chamber, just the same as the 2 chamber, P1, P3, and A2. And then that's the same as your long axis, your apical 3 or your parasternal long axis with your A2 and P2. So beautifully done, Lewis, nicely done. Might make this the last one then if we've got 5 minutes or so left. Do you mind if we just go back to Vishal? Is that right?
Yes.
Vishal, we'll come back to you on this one.
Yeah.
Okay, so 25-year-old lady, she is pregnant, another pregnant lady, 25 weeks pregnant, and she's transferred with marked dyspnea and equirry pneumonia with a background history of antiphospholipid syndrome. She has marked bilateral opacification on her chest X-ray, consistent with possible pulmonary edema. Take me through her images.
So starting with the left upper corner, so apical 4 chamber slightly tilted. So the left ventricle size, is a little bit looks dilated on this particular view. The important thing which is catching my eyes is the mitral valve leaflet looks very thickened, and but I'm not able to see any echogenic structure with any independent motion or anything, but it's just a thickened mitral valve tip on this particular view. The function is mildly reduced. The left atrium is mildly dilated, and probably, possibly signs of left raised atrial pressure because there's a bowing of intra-atrial septum towards the right. Otherwise, right atrium and the right ventricle looks normal size and function in this particular view. Then coming on the right upper corner images. So again, very thickened mitral valve leaflet tips. And so probably, I think in this particular view, I can see a small echogenic structure with independent motion on the anterior mitral valve leaflet. And I'm concerned in between, that's, probably hockey stick appearance as well in the mitral valve leaflet. But I think, parasternal long axis is a better view to appreciate that.
Sure.
And coming down on the left lower corner, so on the color Doppler, so there's significant variance on the flow pattern, which is a concerning of significant flow convergence, which you can confirm with the mitral stenosis pattern on the Doppler profile. And there's a mean gradient almost more than 10 in most of the window, which is suggestive of significant mitral stenosis. So, to summarize, I think there's a thickening of mitral valve leaflet tip with Doppler profile suggestive of significant mitral stenosis. So I'll be concerned about rheumatic mitral valve disease in this particular, which is a cause of mitral stenosis in this particular one.
So you describe the stenosis as being significant. Do you just want to try and give me a value? Mild, moderate, or severe, in other words?
Is it severe? Yeah.
Nice. Are there any confounders to that measurement?
Yeah, so the first thing is the heart rate and, what's the patient's hemodynamics, because
let's say the hemodynamics are normal, she's just short of breath, and the blood pressure is normal.
So
anything else? Any other confounders to that mean gradient being greater than 10?
So patient is critically ill, and so which can increase the gradient through the valve, which can increase the pressure gradient. So that's, so there's a significant, at least moderate mitral regurg you can see, and so there are 2-3 factors let me rephrase. So there are 2-3 factors I can think of. So first thing I mentioned that there's a signs of raised left ventricle end-diastolic pressure. So that's a confounding factor which can increase the, the gradient. And
Nice.
second is the mitral regurg, which again can increase the, flow through the mitral valve, can increase the mitral gradient. And the mild tachycardia as well, which is also a confounding factor. So these
Very good.
three things I can think of.
Very good. Let's, in the meaning of time, let's go through this. So here we can see that we've got significant mitral regurgitation, and you mentioned all the rest of it. So it looks like there's some mitral stenosis in there. The exact severity is difficult to try and tell, particularly when you're critically ill, and we can use the continuity equation to try and figure that out. Lots of B-line patterns in there, consistent with pulmonary edema, which matches her clinical story. Let's go through to this.
So
This is the
transesophageal view, and let's say it's a 0 degree, so it should be the 4-chamber, view. So again, the mitral valve leaflet tips are looking very, very thickened at the tips, and hockey stick appearance on the anterior mitral valve leaflet with significant flame-shaped jet through the mitral valve opening, and also some probably some regurg, and actually moderate mitral regurgitation we can see with the probably Coanda effect, and it's a directed towards posterior mitral valve leaflet. So again, all these features are suggestive of at least moderate mitral stenosis, but I need to confirm with the mitral.
Sure. What do you think the diagnosis is?
So based on the history, because based on the stem, it's the antiphospholipid syndrome. So
Yes.
I'll be concerned about the non-bacterial endocarditis in this patient.
My man, I thought you were going to go down the rheumatoid arthritis thing. Because what do you think about particularly this view on the left? I mean, take me again through what you think of the mitral valve apparatus.
So it's, I was thinking about it's not classical rheumatic valve disease, because, it looks very, very echogenic, chunky, very thickened, kind of, it looks like there's some kind of mass on the leaflet tip.
And particularly the posterior one, I think. I mean, it's
Yes.
Both of the leaflet tips are very thickened, but I don't think any of the rest of the apparatus is thickened. And I think this hockey stick appearance that we talk about, rheumatic mitral valves look very, very different. And I think these are just masses, and particularly that posterior leaflet on that tip there, that's got independent motion, I think. And I think the degree of regurg is also out of keeping maybe with the rheumatic valve disease. So, I mean, I think exactly as you said, I think this is potentially non-bacterial infective endocarditis. My next question is obviously going to be, what is your differential for a mass on a heart valve?
So I'll think about thrombus, infective endocarditis, non-infective endocarditis, and some degenerative calcification disease, normal variant, and lambal excrescence on, if it's aortic valve, and papillifibro elastoma.
Very nice. And just generally, you could just say maybe neoplasms as a whole, either malignant or primary.
And Sam, would you say there's a, I know it's not important, but would you say it's a hockey stick appearance or not in this one?
No, I think they're more like masses on there. And that's why I say this is the money shot, because I think the actual valve is probably okay. I'm sorry I can't slow it down, but I think both of those things are just big dollops of something, non-bacterial infective endocarditis, I think, on the end of the mitral valve leaflets, because she's got antiphospholipid syndrome.
Very globular.
Yeah, absolutely.
Yeah,
so it's very, very
swinging
globular.
Swinging back around the end. So it's not the valve, is it?
That's exactly what I think. And I've got to be honest, I don't think this would be pass or fail in the exam, getting the diagnosis. And if you said, rheumatic endocarditis, rheumatic mitral valve, that's not bad. What's more important from the exam point of view in these kind of scenarios would be having a broad differential, right? You've got to be saying, just like you said, that you've got thrombus, infective endocarditis, that's bacterial, non-bacterial. You can have normal variants, you can have tumors, you can have iatrogenic material. And I think you smashed that out of the park. Nice. that's it, guys. I think we'll just maybe call it a day then. I just want to see how you guys are going, particularly those who are sitting the exam this year. Have you got any questions for me? Because maybe I'll just stop recording. I'll just say thanks for that at the moment, but then I'll give you guys to ask me some questions if you want at the end of this. Were there any questions about the cases, first of all?
I was going to ask, for that first case, especially in the second series of images, can you get right heart stress co-optic Takotsubo's, and could that explain that?
You can certainly get the literature that I know and from my own sort of experience looking into it is that the Takotsubo cardiomyopathy absolutely can have right ventricle involvement. The evidence would suggest that if it does have right ventricle involvement, it's associated with worse outcomes, but it happens with the left ventricle.
Right, okay.
So you don't just get isolated RV sort of stress-induced cardiomyopathies. Having said all that, we certainly see isolated regional wall motion abnormalities, but it's usually associated with acute increases in So there's a wonderful sonographer called Leah Wright, who's done some work comparing acute pulmonary hypertension versus chronic pulmonary hypertension, and the differences in the regional wall motion abnormalities, and particularly in the chronic pulmonary hypertension, she describes acute regional wall motion abnormalities with relative mid and apical hypokinesis. All right, thanks guys. I will stop recording.
If you learnt something, hit like and subscribe to our channel for more videos uploaded weekly.
For bite-sized versions, follow us on Twitter @EchoNepean and check out the tutorials.
Or head over to our websites for the latest hands-on courses. Links in the channel banner.
And thanks for watching.